delayed. They told me we should hurry up, that you will have dinner break afterwards. I try to be in time with my talk. My name is Stockl. I'm the president of Austrian Orthopedic Association this year and last year. 2 years is enough. And I should talk about infections. Prevention, it's very easily to say we're following the guidelines and operations, what we do in prevention. It started with all intra-articular operations that we do antibiotic treatment a half hour before. That's it. That's the prevention. The other prevention is be careful and hold all the standards of hygienic treatment in your OR. The other things are problems. So, you are all from Europe here?
Yes, we are.
Yes. And all residents?
All residents.
All residents.
All
Okay. So, we can answer questions within between the topics. I have 3 topics: osteomyelitis and osteitis, spondylolisthesis and spondylitis, and periprothetic infections. So 3 topics. We start. It's always the same. If you look at the pathogenesis in infections, you have it hematogene, post-traumatic, postoperative, or per continuitatem in this bad diabetic feeds and all the ones we have. I'm an orthopedic surgeon, so I don't talk about trauma cases. Yes? And acute and chronic, that's clear. And you always have to decide what you do, if it's acute or chronic. Then you have different techniques. The very, very important thing I always tell all my students is do a careful anamnesis when you have time. When it's acute, you have less time for anamnesis and you have to hurry up when they're septic. But when you have time, do an anamnesis. And with the anamnesis, sometimes you find out problem pathogens. Yeah? You have never thought about. Even people traveling around in Asia or somewhere else or in Africa, they can have very different pathogens to ours. And you have this in your eye. So, of course, lab parameters, you do all this. And in radiology, a lot has changed in the years. But the main topic nowadays is the MRI. It's going more and more and faster in front of the detection of an infection. And if it's not clear how active your bone infection is, you can do a bone scan or leukocyte scan. Or, if it's possible in bigger hospitals, a PET scan. With the PET scan, you have the activity of the process. And then you can decide what to do. It's extremely important in chronic osteomyelitis when you decide to do an endoprosthesis afterwards. You don't know what's happening in the bone, and if you start with your endoprosthesis, you have the infection 1 month later. So all these cases go in a PET scan in our hospital, and we can be sure there's something going on or not. And always, and that's the most important, the detection of the pathogen, if it's proper. And we do ultrasound-guided or CT-guided aspiration. And then we know we were in the focus and not out, to be sure that you are in the focus and not somewhere and you think it's nothing, or you have the wrong pathogen. You always must try to identify the pathogen, even you had an antibiotic treatment before. If you have time and they are not acute, then switch off the antibiotic treatment more than 4 days and try it. Because with PCR we have chance to find out the pathogen nowadays. Even we have co-infection sometimes with any determinants of proteins. But mostly we succeed now with the PCR in our hospital, and we have within 4 hours the pathogen and we have the sensitives of the pathogen. And send it also to the pathology and do microscopy of the pathogen. Sometimes there's something beside the bacteria. We have mixed infections, especially in old cases, that there are fungus in there. And don't forget the fungus. The fungus is sometimes a big, big problem. You succeed the bacteria, but you have the fungus. Yeah? Even in periprosthetic infections. And these are old pictures from my science work in Innsbruck before changed to Klagenfurt. And there also started from. And we very, very early started with CT-guided aspiration, as you see here. And when you see on this X-ray, this was a young woman, not too old woman, and here is the soft tissue, a little bit larger. You won't see it if you don't reflect on it. And it's a little bit difficult in this height to go in so over. So CT scan is proper better than concave the aorta in front easily. And the next topic is, if you have infections, is the bone stable? Then you have to think about your technique you use, or even on the extremities, if you have to do amputation or not. Or if they start to give you neurological symptoms like paralysis, instability of the spine. You will see this later on. And the indication for surgery is, of course, necrosis, when you have areas where the bone is obviously dead. A dead bone is worse in an infection, because a dead bone means material where the bacteria can live in. Even you succeed with your antibiotics, after some months it starts again. So necrotic areas have to cut out, or sequesters, they're dead. Instability, danger of the neurological symptoms, ain't failed therapy. After 12 weeks treatment, and you don't succeed, you have to think over what you're doing. And sometimes you have to change from the conservative way to the operative way to cut something out and to get the right diagnosis. And we have a problem with evidence-based, like we have the problem with the periprosthetic infections we see later on. Evidence-based is very, very hard to achieve in topics with infection, because the most patients are not comparable and the settings are so different. So we're always in level 3 and mostly 4 therapeutic results and nothing else. And they're all right in the end of the conclusion. Randomized prospective studies has to be done. How? If you give me a study protocol, how I can deal on with infections with prospective randomized, and I can succeed the ethics committee of my university, I would be happy. And you can send it to me, and you come and you work in my hospital. So, osteomyelitis. These were our patients, number 30. 14 were hematogene, postoperative 4, postoperatively 8, and local infection at the diabetic foot 4. Chronic and acute. Here you see where it was, and we had some erysipelas and abscess, flag mounds beside, and spondylitis beside the foot, infect, and so on. It's just typical, and also the bacteria are typical, mostly Staph aureus in 83%, 2 MRSA. We were very lucky in Tyrol. At this time we had way less MRSA, but we had a lot of patients from the south later on. From South Tyrol, it's a part of Italy, and more from the south, and there is a problem with MRSA. Also in the south of Carinthia, Slovenia, we're getting more and more patients out of this area with MRSA. Streptococcus is a problem because they're very, very acute, especially after dental intervention. Sometimes 2 days after dental intervention we have acute problems with streptococcus, and you have to focus this. And these are rare. And that's our basic antibiotic treatment. I worked a lot of phosphomycin, and the combination generally is with a second generation cephalosporin. Since 15 years we succeed with this combination. The problem is phosphomycin is only able intravenous. We have no oral possibility. But after 2 weeks treatment, you should have succeed. And then you can switch over to oral medicaments like fusidin, rifampicin, and so on, the normal standard. Okay? Or Kinodons. And the OP indications, again, abscess, sequesters, fistulas, instability of the bone, danger of affecting the joint. If you have somewhere an infection in the bone and the joint is very close and the infection is going to the joint, you have to operate, because when it's in the joint, you have major problems. They will never be clean, really. And that's a big problem with infiltrations of old knees nowadays. We get more and more infected knees after infiltration. It's got paid in the outpatient clinic. So they all put cortisone and everything, and even in big arthrotic knees, and then we have the infection. In surgical treatment is normal. Incisions in acute situation, curettage and debridement, fixateur, and we, in the big defect, muscle transplantation with the plastic surgeon, that we get a good muscle in this dead bone which is transporting our antibiotic in this field of infection. That's the goal. Yeah? We had very chronic infections where we were fighting with, but with a good muscle, with blood, we succeeded. So, some cases, all the cases I let in German, it's tremendous much work to translate all this. I can just explain it. This was a 51-year-old man with diabetes, and he had heart pain in the foot and in the chopra, and we had to do a panarthrodesis. This is 4 years post-operation. You see here the sequester? It was working with a fixateur extern. 61 years old with fistula staph aureus. The anamnesis is for 1 year, and you see here in this old fracture part the chronic osteomyelitis with this dead bone. We have to cut out something of it, and we put on a myocloplan flap, and after 3 months we had a fistula, and we had a fistula revision, and then it was well growing. And that's a femur with a fistula and an old chronic osteomyelitis, and you see here the bone, the cortical bone, is erodated by this fistula. It came as it must came. We tried to do first the sequestrotomy alone, but the bone breaks afterwards. This is an old sclerotic bone around infection, and then we had to heal it out with a fixateur. It was then no more problem. 1 year post-operative. So the next one, this was one of a hunter guy living high up in the mountains, and he opened his little bladder with his knife. He put it in the fire, then he opened it, and then he put on murmeltier fat. You know what the murmeltier is? These are little animals.
No.
Okay. And with this fat, there is a concentration of 30% cortisone in. And he put it on. And this was a very funny hunter guy. And we did this curettage, and he had a problem with Argos, and he felt it, and we did the fixateur extern. And this was a very dreadful case. It was in the very beginning of my assistant time, after 4 years. And they leave me all alone because nobody likes to deal with infections. And this was a friend of mine in Vienna. And he, in the hospital in Vienna, in the university, they said they can do nothing than an amputation. And I don't agree with them. And there was this gentamicin chains in there. I hate them. Why do I hate gentamicin chains? What do you think? No. They have antibiotics in there. After 1 week, there's nothing left.
So there are still artificial bodies.
So you have then a foreign body in there with no use. And on this foreign body, on this change, and on this little plastic balls there, are the infection going on. We don't use it. Since 15 years, no orthopedic surgeon in Austria is using gentamicin chains. The trauma surgeons like it, but we hate them. And I had to put this all out. It was a dreadful situation, and we needed about there were 5 operations before. So this was the situation we had. Put the fixator on, and we had a 5-hour operation that we find blood vessels where you can connect our muscle flap, the latissimus dorsi flap. And we let this for 1 year, and then I put in a tricortical bone from the pelvis without any screw. We clicked it in, and it was working. But now it healed out, and he is working just with normal shoes. And he's working in a tunnel in Switzerland as an electrician, and he's fine. And we solved the problem. And we had no amputation. It was worth to do it. But we need 1.5-year treatment. This was a long way. And this is a very funny case. I came back from holidays, and they always wait with these cases till I'm back. That's the worst thing when you get in the leading position. They let you everything over. He was in the middle of America, and he got shot in the night by a gangster. And they put in a nail, and this was infected with proteus mirabilis. And I had to take all the necrotic stuff, and this is left from the caliber out and put on ESR. And then it healed with our combination of antibiotics. But it was also a long way to go on. And this was this chronic osteomyelitis, and it healed. And that's another case, and you always have to think, is surgery in some regions really successful? I think not. Especially not in the sacroiliac joint. It's very difficult there. First the operation, the situation, and you have nearly no osteosynthesis material, which is really holding the stability there. So we going from one problem to the other. We tried it conservative in this case. There was this sacroiliitis in here, and the conservative treatment was successful. So these were our results. We succeeded in 76%. It's quite high in these cases. Yeah, if you look in the literature, and these were the therapy failures. One knee infection, we had to do then an arthrodesis. We had no chance to hold it. Then we had one recidive in 4 cases in between 1 and 18 months, and the reinfection in malperformance with different pathogens, which is usual. Yeah. So the summary and the problems are: you need high doses antibiotic in the very first time. So the first 2 or 3 weeks, intravenous therapy. You have no chance normally with normal oral therapies, except you have a pathogen like a streptococcus, then you can change over very, very quickly to oral therapies. Then we have enough power. Surgically debridement and reduction of the pathogens if you need. And then this interdisciplinary way. We work with our plastic surgeons, we discuss this catastrophic patients, and then we decide what is the best way to do. We have now more and more problems coming up with resistant pathogens because these patients get treated everywhere, but often not hard enough. And if you are not succeeding, then the bacteria become resistant more and more and more every time. And another thing is, when you have started the therapy, and after 2 days the patient starts with fever, don't change immediately. Often the fever is only the effect of the toxins coming out of the bacteria when you're killing them. Yeah? And don't switch over immediately. You have time. So wait 1 day or 2, and if you see it's coming up and up again, then there are bacteria. But if you have only 1 time fever, don't hesitate to switch the antibiotic treatment. You have time. We're starting then with the resistance. And the next problem is in all hospitals, the capacity of beds for disinfection patients. I have patients up to 200 days in my facility, and I have only 35 beds in my departments, and we have to move over with the patients in viability units and so on. But the infection patient, no one takes this, so this is a problem. And when I have my budget control, then they hit me because the antibiotic treatments, the costs are very high. So, do you have a question for osteomyelitis osteitis?
So, if you have ups and downs
Yeah.
in the temperature line,
Yeah.
then you can continue to have the same antibiotic for, let's say, 2 days more, just to see.
But when you see this is always coming again, always in the evening, the next fever,
Yeah.
then you know this is the growing time of your pathogen, and then you have a problem with your antibiotic, then you have to change. But if you have only one peak
And then
and nothing, then
okay, then you just continue.
okay, you understand?
Yeah.
Because these were the toxins who were making the fever, not the bacteria.
With the first acceptance of the,
Yes.
of the drug.
During the curettage, do you use to open the medullary canal or not?
I want to have blood in this field, so I open
Yeah,
it.
you use to.
I open it, yes. If you don't open it, you have a dead space
Yeah.
where nothing goes in.
And which is the rate of failure of plastic surgery upon an infected?
It depends. You must make a very good debridement under the flap. If there is infection material, the flap will not survive.
But in the same surgery,
It is
in the same.
okay.
And do you have an experience in vacuum therapy?
We do a lot.
Okay.
We do a lot. More and more. These are data from 2009, 2010. Nowadays we have more possibilities with bacteria, also with irrigation. Not with local antibiotics, but only with irrigation to get all these toxins and bacteria out. And silverback and all this stuff. We do a lot. So, spondylolisthesis is one of my topics I've worked on scientifically over several years, and I speak about the unspecific infection, not the specific infection. And we have also regard the fungi and rare pathogens like in cat scratch disease. I had one patient who had a lot of cats at home, and she had this pathogen. And there's in the literature, it's 1.5% of all pure bone infections, so it's rare. It's really rare. And it needed about 4 years, a lot of talks all over Austria, that I told all the medicines around, the internal medicines, the trauma surgeons and all, please hold the spondylolisthesis in mind. Because often they did nothing because they haven't known about it. So nowadays they treat it very perfectly in Austria because we did a lot of work, and we have not so much of these patients on my department because they treat them now with our rules around in other hospitals. They can give the antibiotics there as well. They always send us the X-rays or the CT scans, and we tell them what to do. And only when they're not stable, we send them to a spine center. So, mostly hematogenous. And that's very interesting. You have a lot of veins in front of the vertebra and around. And the blood flow is, they have no, it goes also retrograde. Yeah? The blood flow is up and down and very slow. And in the bone, the blood flow is also very slow, so the bacteria can stand there. So if they have urogenic or prostatic infection, it can come up from there, or especially in women after birth, when it's concomitant with enterococcus, then it can be that we have enterococcus in the vertebra, yeah, with this blood flow backwards. especially after birth, when the baby walks through the pelvis, then we have the pressure on the veins and coming all back. Yeah. And we had some dreadful cases a week after birth to handle it. Be aware of systemic disease in all of these cases, because this is very different to handle them. And I don't talk about children. Children, spondylolisthesis is totally different to treat than adults. So, it's mostly the vertebral body, and also the dens is very rare, and the transverse is very rare. It's mostly in the vertebral body. There's the spongious bone, there's the low blood flow, and there's the infection. And it's also the possibility of an infection only in the discus, because there are also blood vessels in the discus. So, and these were our data, and it's like Dofek said, it's the same situation. It's around the lower thoracic spine and the upper lumbar spine where the most spondylolisthesis and spondylitis cases are working. And these are all the complications we had before we treated them. So, that was the pathogen. And it's just typical, like in the literature, Staphylococcus and then Streptococcus and then the Enterobacteria here. And the frequency is going lower and lower with this pathogens. So, and again, our treatment. What do you think? I tried to publish phosphomycin in America. Do you think I succeed? No. They hate phosphomycin. Do you know why? Phosphomycin was going on the market as an oral antibiotic to treat urological infections. And the resistance was within 2 days. So all these journals say phosphomycin is rubbish. But phosphomycin is one of the best drugs we have as a co-antibiotic with another one. You can give it also alone, but it's not so safe. But if you give it with cephalosporin or with dalacin or what you like, then it's really good working. And the good thing is, especially also in neurological infections, it's very small molecule, and it walks also into the brain and everywhere. That's very good to handle. The duration was 24 days in mean, and we do our antibiotic treatment in 1 week after the CRP is normal. In all cases, I've looked over in our hospital, there are more than 100, where we had a reinfection, we stopped too soon. Yeah? They overstopped. CRP was nearly normal and they stopped. And so I decided in these days 1 week longer, and then we had succeed. Go over for 1 week. It's nothing. And if the patient can stand it and feel not sick all the time with the antibiotic, hold on. The operative treatment we have talked about before is when it's not stable, when you have neurological problems, when you have a big abscess. But nowadays we don't open surgically the abscess. We can use this solve this problem with CT-guided drainages. And you're in there. Even big abscess, you don't have to open it. Yeah? And with these drainages, you can solve the problem. Because before we had the problem, all psoas abscesses, they tried to operate. And I did a lot of operations with my senior surgeon, and we don't find the bloody abscess in the psoas. We don't find it. We see it on the scan, but we don't find it. We filleted the whole psoas. We don't find it. But in the CT scan, we find it. And we can guide our drainage in there, and it solves the problem. In the beginning, we started to put in local antibiotics. Nowadays, we use no more local antibiotics. It's only making resistance, because you don't know how the level is in there, or what's in the end in there. So, systemic antibiotic and only irrigation with anti-infective fluids, if you want, or otherwise normal NaCl.
What do you mean with all of that?
Loaded. You can have some antibiotics as an irrigation. Yeah, and I don't like that. Or put in chips, bone chips with antibiotic, or any target with antibiotic, because antibiotic is going, and your death space is in there. Yeah, I don't do it. I don't like it.
What kind of solution do you use? What kind of solutions do you use?
Lavacept is an anti-infective agent, and it's good working. Also, intraoperatively, we use it always to clean the whole wound with an irrigation system. We clean out all the place. And we had systemic diseases like diabetic in 8 cases, and a lot of people having, the older people having problems with the liver. So, we succeeded in 75%, and this is high in these dreadful cases. And the therapy failure was one exitus, an old woman. This was the one with the with the spondylolisthesis in the dens, and one recidivist. So, and these are cases I want to show you. L3, L5, 4 to 6 years old. She had rifampicin before, a fistula since 1 year, and nobody bothered about. And we found in the fistula MRSA. And we failed in this case. And that was the foot, a Charcot foot, infected. We had to do an amputation. So, and she had a persistent fistula. After revisions, we tried it first with a bone. This is in 2007 around. We don't use it anymore. We have now more the fixators and other systems, and it was not stable, and we tried it, and we had no chance. So we left her over with a well-controlled fistula in this age. So this was the one who died. She had a spondylolisthesis between C1 and C2, which is a big and huge problem, because you have the choice to operate transferally, and the morbidity in this operating technique is up to 50%. And we tried to hold it with a dorsal stabilization, and we failed. And she had an exitus after the operation. So this is a success case. She had an incomplete palsy with a spondylolisthesis in thoracic 7 and 8. She had tuberculostatic therapy before, but in the drops we had and the aspirations, there was no tuberculosis. But she got treated for 1 year with that. And that's the thing what I meant. When you are not succeeding within 12 weeks, nothing is happening, then you have to think about, is your diagnosis right or wrong? And then you have to decide to get a new probe, also in histology, to be safe. That's it. But you're handling on, and not dealing with tuberculosis where it's not tuberculosis. But on the other hand, tuberculosis is becoming more and more and more, yeah, with this migration of so many people from the east. Within 14 days, the CRP went down from 14 to normal, and we did then the operation with a fusion from ventral. Now that we would do it only from behind with a fixator. That's the post-operative pictures after 1 year. And there you see the CT scan with the operation technique he used in these days. There's a pity. Nowadays they put this little prosthesis in front there. I'm a little bit aware if these will deal really good in an infection. We will see. When they treated it properly, it can work, but putting material in an infection is always difficult. So, that's another one. We had very quick succeed and we had this operation, and this were now this ventral prosthesis. This is seen very often nowadays. But she had, after half year, again, troubles. And intraoperatively, we found in the histology, in this case, a tuberculosis. So we were wrong. We haven't found the tuberculosis in the very beginning. Now our labos are better. If we have a good aspiration, then with PCR and not the animal models, we find easier the tuberculosis. In this time, we had always the hamster model. You have to wait about 3 or 4 weeks if there's something going on or not. I like those little hamsters. I don't want to kill them. That's better doing the PCR. And in summary, it's the same as as said before for the osteomyelitis. High doses antibiotic, interdisciplinary, the operative treatment in the spine center. You have to accuse specific infection if you're not succeeding. And try again to get an aspiration or an intraoperative probe. Otherwise you are lost. This makes problems, and again, we have the problem with regards holding the patients in our houses. So, spondylolisthesis, spondylitis. Do you have questions?
I have one.
Yes.
Do you use local vancomycin after spine? I mean, just after operation?
You mean only powder vancomycin local?
Yeah, powder of vancomycin locally. Do you use it?
Where's the use for it?
There is research or paper about this, that the local vancomycin increases the risk of infection.
Yeah. When you use them systemically also vancomycin?
Yeah, we use it systemically after scoliosis operation and any spine operation.
As prevention?
As prevention, yes.
It depends really what pathogens you have in your house. We don't use vancomycin as a prevention. We have cephalosporins as to prevention because we have no resistance.
Yeah, of course, we are also using cephalosporin intravenously, I mean locally.
Vancomycin is not as good as we thought 10 years ago. I think we have to remove vancomycin in some years because other drugs are more effective even in going into the bone. Vancomycin has there a lack. It's not very good going into the bone. Okay. Is there another question? No? So we continue. Self-prosthetic infection. I had yesterday a talk in the Vienna room about 1 stage, 2 stage. So I put this in, go quick over. We get more and more revisions. The standing time of the prosthesis is going worse, and we have a lot of infections also in primary, in TKA and in ATA both. And these were the data we had about 1996, 1998, also in our house with a success of 80%, 83%. And this is rare. Now we are up to about 93% in the studies. And there, when you have listened to osteomyelitis and spondylolisthesis and all the infection, when you have a periprosthetic infection, a chronic infection, you have an osteomyelitis. They always think they treat only the prosthesis, but sometimes the bone around the prosthesis is looking like an Emmentaler, with a lot of holes in it, with a lot of fistulas. Yeah? And that's an osteomyelitis, and I have to treat an osteomyelitis and not the prosthesis alone. Not alone. Yeah, we have also to be aware what's the bone going on. We discussed yesterday 4 weeks. It's rubbish to discuss acute or early infection, late infection. What I said then in the discussion is you have to look at the clinic of your patient. How is the soft tissue? How is the bone quality? Even after 2 weeks, we have highly virulent pathogens who are destroying the bone and the soft tissue within 1 week. Then we have not an early infection in the treatment, and we have a late infection in the treatment in the algorithm. So we don't have to stick on time. Yeah? But if someone is building up an algorithm people can deal with, he has to make a cut. Otherwise, the people who are not trained with these problems have no goal to decide. Yeah? That's the problem with an algorithm. algorithm can only be as good as the biology of the disease, especially in infection. The systemic factors are influencing, and also the local situation with operations before scars and awful bone is around. And this for our algorithm in Austria, I was there in this team, and we had only a very small group, type 1A, where we said one stage. Yeah? And this is only early, no systemic factor, and no soft tissue. Nowadays, it's different, and we succeed more. And these were our antibiotics 10 years ago. Nearly the same now. We have nothing new. And also for the MRSA, it's a better picture for the MRSA than for the not-resistant one. If you want to have a look what you should do with periprosthetic infection, the guy I'm working a lot with is André Trampusch. Do you know Trampusch, Zimmerli, and Ochsner? Ochsner is from Switzerland. They're all from Switzerland. Zimmerli and Trampusch are now at the Charité in Berlin. And they founded the implant foundation there, and you can go on the internet and you can register there, and you can get for free an e-book in English from Ochsner with all infections and orthopedic parts, with bone infection, periprosthetic infection, spondylitis. It's for free. Or you can order their book in French, German, and English for free. Use it. It's a perfect book. It's a good overview about infection. And this is his way, and you see here, acute infection, no problems, then only debridement and retention of the prosthesis. And if it's a chronic infection, it depends also on the time here, and you have no problem with the pathogens. You can go on with a single-stage revision. We'll talk a little bit later on. But if you have problem pathogens, then you have always a 2-stage or 3-stage. Yeah. But if you know what's going on in there and you have a problem pathogen, then you should go on. And that's his differentiation between biofilm. He said it's immature. A biofilm is growing within 12 hours. I did some work on the electron microscopy. It's dreadful what's going on after 12 to 24 hours. There's a big biofilm. So if it's really immature, I don't know. And you see here the discussion between 4 weeks and 3 months with early infections. That's rubbish. You should look at your patients, and you should look at the local situation, what's going on, and then you have to decide. And he says if one criteria is positive, it's an infection. You don't have to handle too much around. When you have a wound like that with secrets coming all the time out, you have to think about this is an infection. Yeah, because there's something going on in the deep. Sometimes it's only up to the fascia, but mostly there's a little hole in the fascia and it's coming out of there. So be aware. And this is one of the pictures of my scientific work. This is a biofilm after 12 hours. These are the staph epidermidis, and these are the collagens they produce. This looks dreadful for me. It's a really big layer going on, and you can't remove it. And the problem is with identification that we often have poor inoculum, then this biofilm bacteria, small colonies, and so on, until the problem we have in the transport and the inadequate handling in a laboratory who is not used to go on with these probes. So you have negative probes, and you have a bacteria. So always you have to decide. What we do with all prostheses, we cut out, we all send into solidification, all of them. And sometimes they do for us within 4 hours PCR, and then we have a pathogen and his sensitiveness, and we can change our antibiotic prevention treatment within this time. And then we are in this gap of the 12 hours where the biofilm is coming up. It's the one on the surface, the race. You must win it, not the bacteria. So your antibiotic treatment should be safe. But it's not good when you say prevention and you start with vancomycin. Because when you do all treat in your hospital, all in prevention with vancomycin, then you have the problem that they all move in direction MRSA. You treat them, and bacteria are horrible. If you treat them with that, they get resistant. They learn to stay alive. That's the problem with that. These are the problem pathogens. Rifampicin-resistant Staphylococcus, ciprofloxacin-resistant negative bacteria and fungi, and we have mixed infections with fungi or here in 10%. Yeah, you must be aware of that. And in all cases with this pathogens, you have 2 stages or 3 stages. You don't think about 1 stage. This is then over. You will not succeed. But it's very cool. You go to Congress and you hold there a speech and say, I do 1 stage and we have 100% succeed. Then I know this is the next liar I have to recognize in my life. No one has 100% succeed in infection surgery. No one. You have up to 7 or 10%, even if you do it proper, will fail. And there will be a guy, Winkler, he makes the vancomycin bone chips in his firm, and he puts them in everywhere. And he said he is always succeeding with that. It's not true. I had the 3rd operation. So, and this is the algorithm for his antibiotic treatment. And in the 1-stage revision, he gives 2 weeks the antibiotics intravenously with biofilm activity. And here this is the 3-stage revision where you have to exchange the spacer, because the spacer is also a foreign body. And the spacer can also, when they have been loaded with the wrong antibiotic, then they have also biofilm on it. And then the bacteria will also cover the spacer. So you have to put it out. It's the 2nd operation. And then you go further. You got it in the point? Settling? The principle? So, and that were the new literature. Gerke is from the Endoclinic in Sahar, and they do a lot of 1 stage. They have a perfect microbiology doctor in Hamburg. I often have him at the congresses I do, when I have an infection meeting, I ask him for a talk. He is perfect. They have they identified the pathogen. He is writing the surgeon how many antibiotics he should give into the cement and how long he should do the treatment. The surgeons, they don't have to think about. He's thinking for them, and they get the result. So, and what they do in Hamburg is they do a lot of department. They really cut everything out. Everything. And so they have good results, but he says the determination of the infection must be before. He knows his pathogen, then he is doing 1 stage. That's his goal. And he is working along the algorithm of Trumpus. He's fully agreeing with him. If you have the appropriate patients, then 1 stage has the same results than 2 stage. But only if you have to run pathogens. The problem is in this meta-analysis that you have no comparable groups. That's a big pity, and we have only a cohort of patients. We have only detailed retrograde situation, and they're not comparable. So this is a pity. And the reinfection rate in overall in 1 stage or 2 stage was about 10%. So we getting better and better. But be aware, these are centers that do a lot of infection treatment. These are not the results of small centers who are not used to deal with infections. Also, this is a reinfection rate only of 8%. It's also meta-analysis with all the problems they had. And then they said, we have to do randomized studies. Yeah. Do it. I don't know how, but do it. And also here, reinfection rate was only 7% in highly selected patients. What is highly selected? There must be the good ones. Yeah? The good ones where everyone has a chance. And their control rate of 93%. So it's coming up also now from 83% 15 years ago to now 93% in centers who deal with these algorithms. All the countries have algorithms. USA have an algorithm that's a little bit different to Trump-Bush. They decide not so much as he did, but Trump-Bush have a lot of back work behind this algorithm as a microbiologist. And that's the important thing. He understands the bacteria. So, and that was very interesting when I did the literature research, the retention of a prosthesis. I have learned to put everything out. You asked Professor Günther if he can take everything out. I don't care if I can get any part of the cement out. Sometimes I have to destroy everything when I have to remove the cement. Especially when you have a form of a prosthesis, then you have like a bump of cement down there in the femur and you don't get it out even if you have the ultrasound cement remover. You won't get it out, you destroy the whole of the bone. And if it's an old patient and I see this is very hard sticking, I leave it in. Because I think when I destroy everything and I have then to use a mega prosthesis afterwards to solve the problem, my infection rate is going higher and higher with this mega prosthesis, and I have to find the balance. And when this is an old patient, an 85 years old woman, I stop them. And I say, okay, I tried all my best, I leave the rest in, and I go on well with it. Yeah? And last week I had an old woman, the trochanter massive had really an osteomyelitis, was gone. But she has a distal, well-fixed revision prosthesis. And I controlled the bone. It was like marmor boring into all parts of this porous surface. When I have to cut this out, I have a destroyed bone about 15 centimeters. So Hunter's gun, 15 centimeters, so I have to resect about 20 centimeters. So I'm up to a tumor prosthesis when I have to build in again one thing. So I have a problem. I covered it with cement as I'd done before in several patients and was succeeding. But this is the problem. Can you do a study on these cases? No. This is only your skill and your experience you have in the OR. But there are some people so trying this way and they have success. And this was a young man, 16 years old. I put out the osteosarcoma of the tibia and he had a well-functioning prosthesis. This is a maker prosthesis from Link. I'm one of the designers of this prosthesis. And it was well going, and then he had his chemotherapy after the operation, and then he got his staph epidermidis growing after the chemotherapy. The chemotherapy pushed his immune system down and he got the infection afterwards. But the prosthesis has grown in properly. There was no chance to get this bloody stem out of the bone. No chance. So I had to decide 16 years old. When you see here the resection is about 15 centimeter. I have left bone under this prosthesis to the joint about 5 centimeter. What's left when I take it out? So I decided, going another way, I covered the conus with cement, with the spacer, and it healed. And this is then after reimplantation. It was at 2008. I know this boy, he's in contact with me, and he had no reinfection until now. So, should I put it out or not? That was my decision. 2008. And it was well going. But it's not state of the art. Okay? So, some cases, as you see here, there was a spondylolisthesis and this knee. You get this trash in the centers. And we solved it with two-stage. This was a HEMI, then a failed arthrodesis, and then finally we had to do this arthrodesis nail. Another case, dreadful, with spacer, and ended in the amputation. I'm going quickly over it, we are otherwise over time. Think about, I have heard Günther, young patients, our patients with prosthesis getting younger. And they only tell them, you will get a prosthesis, and you're well, you can play football, you can go skiing, you can do everything. I always tell them, be aware, we have infections, and be aware what you do. And after he really recognized everything, then he can decide. I have the most amputations in Austria in these cases. Do you know why? They had about 10, 15 operations before they come to me with a history like that, with all the pathogens, and they are multi-resistant. There's no way to go on. And then they say, we don't go anywhere else to the amputation. I don't trust anybody else. And after the amputation of these patients said after treatment over 5 or 6 years, that when I ever have known this before, I would have done the operation earlier, because now I have back my life. They are sick patients, they have a white skin, they look awful. And after the operation, they knew. But the pity is, I hate amputation. I don't like to do it, but the people say, we don't want to go anywhere else. We are out. So, hip prosthesis. This was a Staph aureus, and another case with this dreadful prosthesis, this Lord prosthesis with this porous coating, and it's, we say I was a Lord when we see it, because you have problems to take it out. You have to split the bone. And this, he had an infection, then a lung prosthesis in there, and going on and going on. And it was sterile in the amputation. And what do we have to do if we do an extra articulation? We solved his leg with a total femur family, and he is now well going on. Or here with this saddle prosthesis, have you ever seen a saddle?
No.
No, it's very rarely. Sometimes I do one in cases with tumors, but it's very rare.
It's German, no?
It's from Link, yeah. And you see here what happened, how many operations. Or here another one with the dreadful situations and infection. And this here was a tuberculosis. So if you have old fistulas, please do some biopsies, about 6, and send them all to the microbiology and to the pathology, and they should search for tuberculosis. Old fistulas are often co-infected with tuberculosis. That's the MRI of him. And I decided removing everything and make no more prosthesis. And in the last 10 years I had to do 15 hip exarticulation course of prosthesis. They're coming high acute with the helicopter in our center, and they're coming to the intensive care unit, and then the anesthetist calling me and say, we have no chance, the liver and the kidneys are going, and if we don't take it out or do the amputation, he has no chance. And we had often only a chance with hip articulation. So, I believe in this algorithm. Look at it, go on the internet, and you can also get an app on the Androids and on the iPhones from the Implant Foundation, where you can give in the pathogens you found and the problems you have, and you can send them, or they have a solution in this app. It's very tricky. And if you have any questions, you can write them. And get the book, it's free. And it's good. So, my credo is for my patients when I do periprotetic infections and even revision arthroplasty, as much as needed, as less as possible, that I hold them alive. And that's it. Thank you very much. Do I have some more questions? No? You're ready for coffee now? I think so.
I have some.
Yeah. He likes the coffee.
No, if you have experience about fibula flap versus Lizaro, this one, when you make removing a part of the aphysis,
Yeah.
and I saw some Lizaro and external fixator, and I wanted to know if you have experience with fibula flap with plastic surgery.
They do it in infection case. I don't like very much having in one situation a bone and a muscle, because the bone often getting dead, because the blood supply of the bone is tricky. And if I transport in the bone in the infection, I have seen very bad results. So I think a two-stage situation with the fixator putting first in the flap, let the infection heal, and then put in the bone in the second stage. For me, it's better. But there cannot really.
Our theory was because endovenous drugs and